So what are your favorite maintenance strategies?
Right. So Len is the most studied, of course. The IFM, the CLGB 100104, the Jemima, study. So there was the meta-analysis that was published in 2017 that showed an improvement in PFS overall with Len maintenance, 53 months compared to 23 months for placebo. And this was a median follow-up of like 80 months. It's amazing. And the overall survival has not yet been reached for lenalidomide. It was 86 months for the, for the observation. And, patients with high risk were also shown to benefit from Len. But on that study, many patients actually did not have cytogenetic data. But on the other hand, the study by Jackson, the UK study, they had over 1,000 patients that they randomized to Len. So like 1,187 patients to Len versus 834 to observation. The follow-up was a little shorter, it was 31 months, but the PFS was 39 months for Len maintenance compared to 20. And all patients in that group actually benefited the high risk. For the transplant arm, those who underwent transplant, the PFS was 57 months versus 30 months for for observation compared to the maintenance. So it goes along with the CLGB trial, 53 to 57 months. And for patients who are not transplant eligible, the median follow-up was 30 months compared to the median PFS was 26 months compared to 11 months. And that goes along with the previous trial that was done by the Italian group that looked at, NPR, melphalan, prednisone, lenalidomide, followed by Len versus maintenance that showed a PFS of 30 months for the maintenance compared to 14 months. And all of these, the maintenance was until, disease progression. And in the UK study, it actually showed patients benefited even if they were high risk or, regardless of stage or cytogenetic risk or age or even CR status, they really all benefited. Bortezomib is another one that, patients with high risk will benefit from, bortezomib. So kind of, I categorize if patient is standard risk, maybe just Len alone. Patients with high risk, I still like Len, but I probably, add bortezomib, to lenalidomide because these patients, you've used bortezomib initially and they have peripheral neuropathy. Even though you're giving it every 2 weeks, sometimes as the standard kind of maintenance, they can still have increased neuropathy. But adding that proteasome inhibitor to the high risk has been shown to actually improve PFS more so, and even overall survival by the HOVON trial by Schoenfeld in 2012. So there was an improvement in PFS from like 13 months to 30 months and the overall survival from 21 months to 54 months. That trial though gave, vincristine adriamycin dex as the induction therapy, most of these patients. So it's hard to, tell. But I do those. And then Nilaro was an option in the EMID. I can combine that with lenalidomide. I don't know where Nilaro fits in your category in terms of doing it as a maintenance, but the IRD study by the MMRC Multiple Myeloma Research Consortium showed that when they compared Len versus Nilaro as a maintenance, in fact that study, the interim analysis showed that there were slightly more relapse in the Nilaro arm than Revlimid. So the study was patients who were in the Nilaro arm or ixazomib arm were actually informed and given the option to move to the lenalidomide arm. So maybe you can comment on some of those.
Yeah, so that we were part of that trial too here at UCSF, and it wasn't a statistically powered study to compare Len versus ixazomib, but certainly the statistics were that ixazomib wasn't going to be able to beat lenalidomide. So that's why we just kind of as a group said, all right, well, maybe everybody should just get Len since it's the tried and true. And I totally agree with you. That's what we use for standard risk is we use lenalidomide maintenance 10 milligrams, we start off, daily. And then we try to increase it to 15 if the patient can tolerate it. And then over time, often you have to adjust the dose. And so it's all really about adjusting the dose. I did like Dr. Nuka's study from, even though it was a cohort study from Emory, where they looked at their high-risk patients and they gave them RVD for 3 years, right, post-transplant. And those patients, those high-risk patients actually did quite well with a PFS of, median PFS is over 30 months, better than what we expected. I do use RVD in the high-risk patients. The two trials that I'm really looking forward to seeing, well, more than two, but the two that I think are going to be interesting is using lenalidomide. There's a couple studies that are doing lenalidomide versus lenalidomide and DARA as maintenance. So that'll be pretty interesting.
Yeah, this work one is one of them. Yeah.
Yeah, and the other one is the Forte trial, which used KRD as induction, and the maintenance. Some patients got a transplant, some didn't, but the maintenance is actually a randomized of just lenalidomide or carfilzomib and lenalidomide for maintenance. So, and there's some high-risk patients in that study too, without Dex. So that'll be interesting. Those I'm actually quite looking forward to.
Yeah,